Welcome to Continuing Education Module number 32, Selected Prevention Aspects of the Affordable Care Act, a view from the wellness field. Our agenda for this particular module is as follows. First of all, we're going to look at some basic background on the ACA. Secondly, we're going to deal with the features of the ACA that support worksite wellness. Then we're going to look at features of the ACA that undermine worksite wellness. And then how to adopt the positive features into your program now, and possible improvements to the law that may take place during the changeover in administrations, and the summary of key points. Let's first look at some basic background on the Affordable Care Act. And I think it represents one of the most highly partisan approaches to healthcare reform and solutions for the healthcare system that we have experienced as a nation. It's also one of the most extremely complicated pieces of social legislation that's been passed. It goes to over 1,400 pages. It's a significant piece of legislative acumen. There are some 457 separate legislative initiatives in the Act itself, and almost all of those have been contributed by Democratic congressmen and senators that have crafted and were able to craft the legislation in its passage in 2010. It really includes almost everything but the kitchen sink when it comes to healthcare reform. It tries everything. And it's a major step toward universal coverage because I don't believe that it's going to be successful, and that will likely then lead to more political discussions about moving our healthcare system into more of a universal coverage and probably more of a single payer system. The universal coverage portion that requires coverage for called the individual mandate is actually a good long-term approach. The issue is that everyone needs some protection, but we don't need the level of protection, in my estimation, that comes with the ACA. I also would like to comment that my graduate training is actually in medical care organization, and it dealt with insurance, national health insurance, and looked at a lot of the evidence around how we might structure our health insurance approach as a nation. So the comments that I'm sharing with you come from that background from the University of Michigan's School of Public Health. No new mechanisms for cost control were contained in the Act. So I read through the entire Act actually twice, and the 457 different features, I did not find any new mechanisms that have not been tried before. We actually put some new names on things like value-based reimbursement, but we don't really have much new content or new approaches embodied in the law itself. It greatly expands the federal and state role in healthcare, and primarily by providing subsidies to a significant portion of the population. It uses primarily non-market solutions, so it's not attempting to deal with the primary market imperfections that exist in healthcare. What it does do is it essentially sets up triggers and thresholds which really are non-market solutions to attempting to control the rate of future growth in healthcare costs. It also provides, fortunately, a major focus on prevention and wellness, and we're going to go deeper into that as we go through this particular module. Now, the overview of the ACA, there are 10 titles, and these titles, by the way, you can see some overlap in them because they are actually the result of the combining together of several major legislative initiatives that never got very far in Congress, that were in fact brought together and then roughly crafted so that the headings here actually have a good deal of overlap in them. So what our focus is going to be on is actually Title IV, which includes 27 different legislative initiatives that provide about 5.9% of all the sections that are in the law itself. So you can see the 457 total number of sections, and each section is a separate legislative initiative. And you can also look at the percentage that it represents of the entire 457. So you can see, fairly quickly that a big chunk of the ACA is really looking at creating affordable healthcare, doing some things to improve the role of public programs like Medicare and Medicaid, improving some of the way in which we assign numbers to providers and to individuals and to various types of providers of healthcare. It also deals with a good deal of consumer protection, transparency, integrity, fraud prevention. The Class Act, actually number 8, was actually was was removed from the legislation after passage. So that particular piece is not a functioning piece of the ACA. And then the revenue provisions, and then the last section, section 10, also includes another series of efforts to try and bring some rationality, although it is actually non-market rationality. It's approaches that were thought by the staff that put this together, of the various committees and representatives, Democratic representatives of the House and the Senate, when they put this piece of legislation together. Now, the overview of Title IV is as follows, and there's going to be two slides. We're going to go down and look at each one of them. The major headings are on the first part, have to do with modernizing and updating our disease prevention and public health system. So we ended up with a National Prevention, Health Promotion, and Public Health Council, and then also a fund which has not been funded by Congress. So that has only been funded partially at the beginning of the law when it was first implemented, and then afterwards the funds were not approved by Congress, not appropriated. They were authorized but not appropriated. And the clinical and community preventive services, so that sets up the authoritative nature of the two task forces, the U.S. Preventive Services Task Force and the Community Prevention Services Task Force. There also are some outreach and education campaigns regarding preventive benefits. So it's an attempt to enrich the benefits that are provided to employees and to individual health plan members, beneficiaries, around the issue of preventive benefits. And then also increasing access to clinical preventive services, subtitle B, deals with school-based health centers, oral health care, Medicare, the removal of barriers to prevention that has been historically part of Medicare, evidence-based coverage for preventive services, and then the requirement that the task forces weigh in on the policies that will govern the reimbursement of prevention under the various federal and state programs. And then also improving access to preventive services for eligible adults in Medicaid, which allows a more consistent and coherent approach to prevention in the Medicaid programs. Medicaid is federally funded with a match from the state government. It's state administered, but it is federally defined in terms of the general policies and regulations that govern it. And then also the coverage of comprehensive tobacco cessation program for pregnant women in Medicaid. These, as you can see, are some of the kind of the loose ends that got pulled together when they put this particular piece of legislation together. And then Section 4108 deals with the incentives for prevention of chronic diseases in Medicaid. And this is the continuation of what you just saw on the previous slide, and it includes subtitle C, Creating Healthier Communities, which is a new initiative, and then subtitle D, the Support for Prevention and Public Health Innovation, and then miscellaneous provisions. And we'll cover each one of these in a quick form. First of all, the community transformation grants were funded initially when it was passed in 2010. It was actually 2011 and 2012, and then not funded after that time period. So those have been on the shelf, but not funded. The Aging Well, Living Well, the evaluation of community-based prevention and programs for Medicare beneficiaries has not gotten either funding, to my knowledge, or been implemented. Removing barriers and improving access to wellness for individuals with disabilities, immunizations, nutrition labeling, requirements around that. A lot of these provisions basically set up the ability for the Centers for Disease Control and for the Department of Health and Human Services to issue regulations affecting all of these various areas. In addition to the Centers for Medicare and Medicaid Services, which take care of the Medicaid and the Medicare program. Medicare is for our over 65 and special types of Lou Gehrig's disease and end-stage renal disease. But it includes also some people that have disabilities. So there's a kind of a potpourri of Medicare beneficiaries. The Medicaid beneficiaries tend to be what are called categorically, the categorically needy groups, the aid to the permanently and totally disabled, the aid to the blind, and the aid to families with dependent children, and the medically indigent provisions, which cover a particular part of the population in each state. So those are the Medicaid and Medicare provisions. And also there's a reasonable, actually section 4207, it just shows you again the kind of the potpourri of combination of things that were put into the ACA. A reasonable break time for nursing mothers. So it basically requires all employers to give employees that are nursing their newborn children sufficient break time to expel milk and to do all the things around the nursing function for infants. So Subtitle D is the support for prevention and public health innovation. So these address the CDC, epidemiology, laboratory improvement capacity grants, and some pain management issues and funding for childhood obesity demonstration. So there are just a potpourri of different things that were identified by the Democratic congressmen who were involved in submitting things that got into this piece of omnibus legislation. And then subtitle E, the miscellaneous provisions, is the sense of the Senate concerning CBO scoring. So that has to do with how the Senate wanted the Congressional Budget Office to score this particular legislation in terms of its cost and its tax implications and so on. And then 4402 was the effectiveness of federal health and wellness initiatives and set the stage for an expectation that the federal government agencies, primarily under CDC, would in fact conduct evaluations of the effectiveness of many of these preventive programs that were relatively new to the Congress and congressmen and staffers that were putting this together. So what you see here is the content of the 5 subtitles of Title IV, and you see the individual section, each of which is a separate legislative initiative. So it gives you an idea of the kinds of things that were included in the provision around the issues of prevention within the Patient Protection and Affordable Care Act. We oftentimes just abbreviate it as the ACA. Now, the provisions that I believe support worksite wellness, there are a selected number. And if you go into our website, you can actually go back into previous blogs where I was blogging, it was called the ACA, the Good, the Bad, and the Ugly. And I essentially went section by section through the law. I didn't finish the entire law, but I got through about 2/3 of it. And basically just shared my opinions about whether a provision was actually a good idea or not. There was a lot of what I would call pork in here. There was large amounts of money to be given to state government and various sectors that I think would probably be politically kind of a buy-off, and allowed the various kind of major players to support the legislation based on what was in it and what would eventually come to the various parties. So that's you can read about all of that, and I just took and dissected the law, about 2/3 of it. The incentive provisions, 2705, are actually a good part of the law, and it reinforces regs that had already been published in 2013 that essentially allowed worksite wellness programs to use premium differentials and to link the incentives, the financial incentives, to health plan coverage. It sets up the pattern and expectation for those. So those were codified out of regulations. They were actually pulled out of regulations and put directly into the statute itself. And just a little aside, I spent 10 years in the federal government implementing healthcare regulations, taking the statutes that Congress passed for several laws, and then having to develop regulations, work with central office staff and regional staff as the implementing regulations went through the various requirements of how they're promulgated legally. So I have a pretty good sense of how these various things kind of work and what you can expect around them. In the context of our government, the statutes are usually the controlling items. That's where the bureaucrats go back to and look at and see what did Congress mean, what did they want, and then they oftentimes look at things like conference reports and other kinds of statements that Congress makes and consensus which is formed to actually help the federal staff who have to implement a law understand what Congress really intended. What happens then is that the bureaucrat that is in Department of Health and Human Services, when health law is passed, then they are responsible for going through the process of publishing initially a notice of proposed rulemaking. That's kind of a draft, and then a process where they listen to comments and then they formulate final rules. So they can also have interim rules, and they can do a number of things to meet specific requirements in terms of regulatory function. So the idea that you eventually get to a point where you have final rules, and those final rules actually carry with them the force of law. Those final rules are supposed to align with the intentions of Congress and the statute. So this particular move actually took language out of the regulations and put it into the statute to actually bring it into another level of authority when it comes to setting national policy around the area of healthcare and specifically wellness incentives. The preventive medical benefit coverage in Section 2713 is also, I believe, a supporting activity, a supporting element, legislative initiative within the ACA for worksite wellness. I think that it's also an issue of essential health benefit coverage, which includes preventive services. So that's another section that essentially aligns with us. I'm not in agreement with the extensiveness of what the law calls essential health benefits. It really is a very generous set of services. And the unfortunate thing is that because the essential health benefits have a tax advantage to employers, there is a tacit incentive for the use of that definition of what should go into health plan coverage. And unfortunately, what it does is it sets a very generous bar when it comes to the coverage, which is provided by employers and then authorized by the law, and then creating these incentives for employers to follow that generous benefit path. I think we would have been better served by having some real basic benefits, not extending them and having those basic benefits be much more affordable to our own kind of financial and economic realities around our debt, our federal deficit. Right now it's approaching $20 trillion. We have approximately $34 trillion of unfunded liability in the Medicare program between now and 2050. So we've got some fairly large problems around healthcare that were not really aided by our taking a very generous approach to what we define as health benefit coverage. In addition, we have something called the National Media Campaign, which was unfortunately not funded by Congress. So that set up an expectation that we would do much more focused prevention messaging and communications with our population. We still, in my estimation, need to go back, revisit that, fund it, and actually implement it. There also was a significant prevention and public health fund, which included several $billions that were to be distributed to the public health departments at state and county levels throughout the nation and city levels. That unfortunately was funded partially for a couple of years and then defunded. So we are not in a position to be able to build up a public health infrastructure and to support the prevention efforts of a lot of the state and local public health departments. There also was a designated National Healthy Workplace Program, which was implemented by the CDC. You can actually go to their website and see what that program is about. Unfortunately, the funding of the vendor who was supposed to do a lot of the work did not work out, so the vendor ended up getting defunded. So that particular activity has continued, but it's in a sense limping along. The U.S. Preventive Services Task Force and the Community Prevention Services Task Force and their role in setting policy around prevention is addressed in that particular section. So if you take these numbers, you can go back into the law and actually read the legislation and read the issues. You also will cover toward the end of this session a specific website that you can go to look and see what level of actual implementation has gone on around these various things. There's also a strong and clear prevention emphasis in section 4001, which really starts out Title 4. You can see that the number on the front is associated with the title that it's in. So all the 4,000 are in Title 4. All the 2,000s are in Title 2. And then the number one there under essential health benefit coverage is actually in the area of the first title. So these numbers trace back to the specific references and specific components of the law. There also was an authorization for a grant program to small business for worksite wellness, and that was done for a few years, but unfortunately, again, the vendor who was handling that and was selected for that was not able to continue doing it. So that has also been put into a hold. Now let's deal with some of the provisions of the ACA that undermine worksite wellness, in my opinion. First of all, there's a requirement that extends community rating, and there's two sections that deal with that. Those are the two sections identified. And unfortunately, community rating is really a bad thing for wellness, because it takes away the economic incentive for employers to spend money on wellness. They don't get any money back if they end up spending it on wellness if they pay the same amount for health care. Now, you can also say, yeah, but they do get the sick leave benefits, maybe workers' comp if they're self-insured, maybe disability if they're self-insured, and maybe presenteeism. But the basic issue is most employers do wellness to affect their medical trend, what their future costs are likely to be in health. So their health plan costs are part of that. And unfortunately, in the ACA is a clear bias toward community rating. And that's great when you're looking at the national picture and trying to get people's premiums down, which is part of the political trade-off for the passage of the bill amongst the Democrats. But the basic issue is, the unfortunate part of that is that it takes away much of the economic incentive for employers to do worksite wellness. So that's one of the things that is not a good issue, not a good outcome from the ACA in terms of its effects on worksite wellness. There's also some fairly substantial entitlement effects that take place in those sections of the 1300 series. And the entitlement effects are essentially saying to people, the federal government will subsidize your health plan. Don't worry, you don't have to do anything. We'll make it happen for you. You can keep your doctor, or you can keep your health plan. Just a lot of entitlement-oriented kinds of issues. And unfortunately, my belief is that entitlement is not a good thing, because we always want more than can be given to us. And that creates alienation, dissatisfaction, and people being unhappy. So I don't see that as a good thing in terms of its nature and position in the ACA. Another one of the issues is the absence of wellness-oriented risk pools. They are not addressed in the legislation. And unfortunately, that's what we need to be doing for small businesses, is to basically say, if you want to have preferential premium experience on your health plan, you need to be part of a pool where everyone is doing wellness. And those have been set up by a number of health plans. They're very successful. The ability for us to have wellness for the small business and medium-sized business is expedited by that kind of approach to risk pools that insurance companies and health plans can use. So unfortunately, it doesn't. I saw nothing in the law that either allowed it or talked about it. So it can be done, but it's outside any of the concerns or issues that the ACA establishes. The only emphasis is on health plan cost. So that's another one of the issues that undermines worksite wellness, because it really doesn't give us any further identification of the importance of sick leave or workers' compensation costs or disability insurance, short-term and long-term, or the issue of presenteeism. So it's really focused only on health plan cost, and that limits what wellness can actually do and what kind of concerns we might have in terms of a general approach. There's also no dedicated research funding for worksite wellness, and it would have been wonderful if the law itself had included some funding to be carried out by the National Institutes of Health that would allow us to have public funding of the economic effectiveness, the health improvement effectiveness, the healthcare utilization effects of worksite wellness, research into well-being. So we don't end up having any dedicated research in the public sector, and that then places us in a more tenuous position because we don't have support to actually conduct more objective research. The research that is done is usually done by the vendor or by the employer, and it's usually by parties that have some interest in the outcome of the research. So we would be better off if we had, in my estimation, more funding like the National Institutes of Health have, but have it focused on what are the best practices for worksite wellness. Another one of the issues is the limited sense of personal responsibility that is throughout the law. The law does not contains virtually no language that says the individual has some responsibility in their own health. So the law really sidesteps all of that personal responsibility related kind of issue. It also, in addition to that, has a fairly narrow definition of wellness and health promotion. So the definition is narrow. It then kind of narrows the outlook and the way in which we implement and consider wellness, well-being, and health promotion. So that's another place where I think that the provisions of the ACA do undermine some of the worksite wellness effects. There's also a limited fix to major market imperfections. And major market imperfections in healthcare are: one, the individual is financially isolated from the consequences of his or her choices. So in general, there's a good deal of isolation. When you separate the financial consequences from the choices the individual makes, your markets become less efficient. People don't worry about it because somebody else is paying for it. In addition, there's also the issue that we oftentimes don't know the price of the services that we're purchasing. So we are contractors. We go out and contract with various kinds of providers who agree to provide health care to us, but we don't know how much they're charging us because we generally don't see the bills. So that's another market imperfection. We also do not have much information about the relative quality or the relative value of one type of care versus another, one set of providers versus another. Now, there are some provisions that work on that within Medicare, for instance, There's a process that's used to allow people to rate health plans, but I don't believe that it really provides a very effective insight or series of insights for the consumer about choices that have to do with healthcare utilization and where they use healthcare. So those are some of the other market imperfections. In addition, another market imperfection is the entrance into the particular marketplace is fairly restricted. It's pretty difficult to open a new hospital or to set up a clinic. So the idea that we want ease of entrance into situations where prices are going up, you want new entrants to come in. So we've got a lot of also regulatory overlays. There's something like 48 different organizations that regulate hospital care. So just if I used to be a hospital administrator, and I would be working with all of these different organizations that were coming and doing bits and pieces. So there's a lot of those kinds of things that lead to imperfections in our markets. So we don't have good market behavior and market functioning in healthcare. And unfortunately, the ACA does not do much to improve that. It doesn't do much. It just kind of talks about it in very limited ways and doesn't really, move us much further at using market forces to bring about more efficient operation of the healthcare system. In addition, there's still a fairly strong treatment bias throughout the Act. So the idea is in healthcare, we have a treatment bias. We actually don't have a strong prevention emphasis because most of our healthcare system makes money off of treatment, not off of prevention. So even with some of the changes that are included in the ACA, we still have a very strong orientation toward more care, not less care. So that's that treatment bias still being strong. Now, the issues that I think I would recommend that you adopt now have to do with celebrate the fact that wellness is emphasized in the ACA. It does get into both the provisions that the other titles that have to do with employer wellness and health promotion, but it also is included in the Title IV. So we ought to just kind of, first of all, just clap our hands and say, good, that ACA does include more of a wellness and prevention emphasis than we've had prior to the ACA. Use the ACA to leverage prevention. So there's the essential benefit, definition of essential benefit coverage and the issues around that are embedded in the law that have to do with Title IV and the issues around incentives and the use of health risk assessments, and all of those things are in various sections of the law. So we can use the ACA to leverage prevention to a higher degree. I think we want to improve the preventive medical benefit design. The provisions of both President Obama's executive order, which he tried to use that particular source to have all health plans have preventive medical benefits. But unfortunately, there's no enforcement mechanism that goes along with that executive order. So we still have a significant proportion of health plans that are either grandfathered or don't have preventive medical benefits. So one of the things we can do is to use the leverage and the way in which the ACA points to the need for preventive medical benefits to improve that particular provision. We also need to move to premium reduction for wellness. So the ability for us to adopt an approach where if you want to do, it's kind of like if you want to get on the bus, on the wellness bus, we'll charge you less for your health plan coverage. But we are going to add that amount beyond what the actuarial needs of the health plan funding are. And we're going to add a $50 or $100 a month premium contribution and then have that reduced if you in fact do wellness. And I think that is the best way to engage 85, 90, 95% of your population in a wellness program. We don't stop with that because we also want to enhance the intrinsic motivation that goes along with a wellness program. But the idea that in the ACA, you in fact have some opportunity to use premium reductions to reward people for their involvement in wellness programming. You also have the opportunity to use multiple wellness criteria as your end game. So you can, in fact, come up with 10 wellness criteria that include things like tobacco use, physical activity, being current on all your preventive screening. So we can, in fact, use those criteria underneath both the original ACA rules, which came out in 2013 around incentives, and then also the newer rules that have been final rules that have been promulgated by the EEOC around GINA, the Genetic Information Non-Disclosure Act, and also the Americans with Disabilities Act. So all of the regulations allow you to have these kinds of wellness criteria as part of your end game in terms of how you approach this issue of wellness for working populations. It also broadens, you can broaden the health cost management pathways in wellness by including not just the traditional risk reduction activity, but also medical self-care skills, which includes home care skills, as well as the issues around consumer health education, the issues around ergonomics, the issues around injury prevention, the issues around advanced directives. So you have lots of those issues, and we actually get to a lot of those in the level 3 certification program in WellCert. So you can broaden your health cost management pathways in wellness, and you can do that now. You can also add financial wellness as one of the domains that defines well-being or defines wellness to your program. So that's another opportunity for you to use. And you can add a focus on sick leave absenteeism, workers' compensation, disability insurance, short-term and long-term disability, and presenteeism. So there's nothing that prevents you from going ahead and actually including that in your approach to wellness at this point in time in the implementation of the ACA. Now, the improvements to the ACA that I would suggest is, first of all, going back to the blogs that covered about 2/3 of those 457 legislative initiatives, I would repeal the ACA's worst features. And the political context right now is really considering more of this kind of point by point and/or having wholesale kinds of repeal. So what I would do is I'd probably repeal the worst features and try to work with the better features to improve them. I would increase the focus on health improvement. I would formally authorize wellness-oriented risk pools because I believe that that's the best mechanism that we can use to reach the small employer and the mid-size employer, and the bulk of our labor force, 56%, work in organizations with fewer than 100 people. So the bulk of our labor force in the U.S. is associated with smaller employers, and we oftentimes don't have as extensive a wellness effort to offer them. But we can work on that and actually deliver wellness to those smaller organizations through risk pools that require the employer to be involved in wellness programming. We also can work on the main market imperfections. So we have the opportunity to improve the ACA by attempting to really get some market forces back into healthcare, which have been really sidelined by our efforts to use non-market solutions. And we can also emphasize personal responsibility to a larger extent. So that would allow us to take the ACA and actually infuse it with a stronger emphasis on personal responsibility. We can also create a real minimum health coverage. Almost all the political activities I've been involved with over 40 years of working in the field, in the healthcare field, have usually ended up with maximum health coverage, not minimum health coverage. So we can, in fact, create a real minimum health coverage, which I believe would be a significantly good thing for us to do in order to bring much of the cost down for the expansion of coverage to more of a universal coverage. I think that we have to require all to have at least the minimum. So I would be an advocate, and I am an advocate for universal coverage, but not at the level that the ACA provides. I would rather see us have that minimum requirement, something that protects people against the catastrophic problems of healthcare, so that they, in fact, are not bankrupt by a health event. And I would add a new institute to the National Institutes of Health and fund the research on worksite wellness, because we have approximately 84% of the US population associated with an employer. So we have a great deal of opportunity to affect population health and to do health improvement if we in fact had that coverage. Now, a summary of key points. The ACA has some good points, it's got some bad points, and it's got some ugly points. The uglies need to be repealed. The good need to be enhanced. The bad need to be modified significantly. But those go across all 457 legislative initiatives. We can use its features for leveraging health improvement, so we have an opportunity to do that. We can continue to point out the contradictions that exist in the law itself and the contradictions to what we're trying to achieve with worksite wellness programming. We can also continue to emphasize personal responsibility. So we can talk to people about their responsibility, not just their rights to have unlimited health care, but also what comes along with some of those rights in terms of exercising personal responsibility. We also can continue to create wellness-oriented work cultures. So we have the ability to actually work on that particular task to bring our work cultures around to a point where they are more wellness-oriented. We can also stay aware of policy formulation efforts. So as things happen, we in fact need to kind of know what's happening with EEOC's position on incentives, and what about the ARP and its suit against the EEOC for those current regs, and a lot of that policy formulation, legal kinds of issues. We also need to realize that critics will continue to come forward. So we have a number of relatively uninformed but very vocal critics that come from academic background and some failed entrepreneurial work. And they're out there, and they will continue to try to shout down the people who are trying to do programming. Also, we need to have those who persist usually do win, so it's our persistence that's important over the long haul. And there is a lot at stake. So the ability for us to use the ACA to maximum advantage, respond to its requirements, but also to leverage the good parts of it, to try and do something perhaps about the bad parts, and to try to bring about some improvement in how it supports employer efforts at improving the health of their employees and their family members. And let's make the most of it. We have an opportunity. Why not use that opportunity to maximum advantage? Now, let's cover some key questions. First of all, the question people often ask me is, what do you think of the ACA? I think the ACA includes some features that are very appropriate and useful, but I also think that it contains everything, including the kitchen sink, and that a lot of the features in the ACA are counter to what we need to have happen. It also is a highly partisan piece of legislation, a major piece of legislation, and it's got some enormous economic implications for our national debt. So I would have to say that I think that there really is a need to take out the really poor areas of those 457 legislative initiatives, remove them, again, work on the ones that are good by enhancing their goodness, and also those provisions that are bad, that are not ugly, but they are bad, they need to be modified to bring them into a broader and more effective strategy. The problem with the ACA also is that there's nothing in it that embeds discipline into the whole healthcare process. It just gives people more entitlement. It opens up more avenues for healthcare spending. And it also offers more opportunity for healthcare providers to generate revenue. So I don't see it leading up to a lowering of costs in the future. I think that it's a recipe for much higher costs in the future. It takes some good steps toward prevention, but unfortunately, we haven't had political agreement to fund many of those key provisions. So we have them on the books, but we don't have money actually going into the expansion of public health and the various prevention and health improvement efforts that are embodied in the law. So the potential is there, but it's not being utilized. And at the same time, Congress has never demonstrated much discipline around controlling healthcare costs. So whenever Medicare tries to put a payment limitation out, it oftentimes gets overturned by congressional action. So Congress is probably one of the worst bodies that we have in terms of its ability to live within a budget or to cause an 18% of our gross domestic product and the industry that it represents to live within its means. So that's what I think about the ACA. What do you think will happen in the next 3 to 5 years? A lot of it will depend on the political election, the 2016 political election, and how that is going to shape and affect the provisions, the regulatory, and the budget side of the ACA. I think that we're probably going to muddle on. I think we may go through some efforts to repeal certain sections of the law, but I think we're in for a lot of, basically a lot of turmoil during this next 3 to 5 years. What do you think is likely to happen with wellness in the next decade? I think what's going to happen is that the weaknesses of the ACA are going to become more visible as we go through various, implementation of the various provisions. The implementation was actually spread out over an 8-year period. So it included things that would come online in 2011 and then actually end up completely implemented by 2018. So that's the time that we're in. And I think that what is going to happen with wellness is that wellness is likely to go through a period of time where it is of diminished importance because there's so many other things happening. But then as those things happen and we begin to find out that we don't have the kind of cost control, cost stabilization that we were looking for in healthcare, then I think we'll be back to wellness, asking the question, essentially, what are the best practices, the minimum effective dose of wellness that we need as employers to help us better manage the health of our workforce and our population. Now that you've completed this module, go ahead and take the quiz for this one.